Where do you think people should start with their ultrasound journey?
I love people to know that they can learn everything. Like ultrasound is a stethoscope of 21st century. They compare this with a laser machine or HIFU machine. They say that I cannot make money directly from the machine, but I'm telling them it's a long-term investment. You get more patients that they know what they want, and then you being confident, less complications, more precise treatment, and you build your business. The only thing I can say is try to see what others can't see. That's the thing, like always be confident, be safe, and be more precise.
Welcome to Inside Aesthetics, the world's most listened to podcast for injectors and aesthetic businesses. I'm Dr. Jake Sloan, a facial aesthetic doctor, trainer and speaker with over 17 years experience.
And I'm David Siegel, an aesthetic entrepreneur and business mentor who's been working within our industry for over 2 decades. IA is a podcast aimed at educating aesthetic practitioners from around the world. The information contained within our episodes is general in nature and should not be used by the general public to make health or treatment decisions. You should seek the advice of a qualified healthcare professional in your country and have a bespoke consultation.
For our latest news, you can follow us on Instagram and TikTok, and now you can also watch our full episodes on YouTube and Spotify. All of our links are down in the show notes below. Now let's get into today's episode. Hey guys, welcome to Inside Aesthetics, the world's most listened to podcast for injectors and cosmetic businesses. I'm Dr. Jake Sloan, this is David, and as you can see if you're watching on YouTube or Spotify, we are again outside of our normal studio. We're here at the ICCE conference in Cairo. So I guess first of all, thank you to the guys from ICCE to invite us, and to Mohammed Saad, the CEO, for inviting us here. Now, who do we have with us today, David?
Excited. We have your friend, Dr. Roya Zarmehr Zamin. Did I pronounce that correctly?
Yes.
Close enough. You guys met in IMCAS back in 2022, I believe it was, a couple of years ago. And you're from Iran originally. You still live there. You do a little bit of traveling, and you're an ultrasound expert. You're going to be working with Dr. Katafana. He injects his demonstrations only with ultrasound. So that's what your primary focus is here today. And today we're going to talk about ultrasound, where we are with ultrasound. It's a very topical piece of, people are talking about it a lot. There's a lot of people with ultrasounds in their clinics. Some of them have trouble using it. So just unpacking where we're at with ultrasound technology and perhaps looking into the future as well.
Yeah, so Roya, first of all, introduce yourself, your background and where you work. It's quite interesting.
First of all, thank you. Thank you for inviting me. It's a pleasure to be here. And then I'm a doctor for 32 years.
Okay.
And then I'm originally from Iran. But I work in Iran and Dubai and then live in Canada. It's a very complicated life.
Where in Canada?
Toronto.
Okay, well, we're going there next week.
Yeah, nice, yes.
So you got a lot of frequent flyer miles.
Yes. And mostly I'm, I'm living in the plane. I'm doing a lot of, aesthetic treatments, and still always, I want to see more beyond that everyone's seeing. That's why I got into ultrasound.
Great. And when and how did you train in ultrasound? Because this is really the question that we're trying to answer for our listeners. How do you train? How do you do it?
I was introduced to ultrasound in 2020 pre-IMCAS Congress by Leonie and Peter. We had it there, but it was on cadaver. And then we had some hands-on training. And since then, I was just very curious and very interested to do ultrasound. And then during the COVID, I started practicing. And then, I got here. And I love it because it's open your eyes, and then you can see what others can see.
Yeah, I guess to reference Leonie and Peter, Leonie was on episode 175, it was a long time ago now for us.
Feels like a lifetime ago.
With Dr. Stella from America. And that was where we unpacked the basics of ultrasound, why might you do it? But that was quite a while ago now. So I guess the purpose of our chat today is how have things moved on in the last 3 or 4 years since COVID? And I think I did my first course at that IMCAS event. I did just a very simple course with the Clarius device. I don't know which brand you're using, so you can tell us. But just unpack, where do you think people should start with their ultrasound journey?
I love people to know that they can learn everything. Ultrasound is a stethoscope of 21st century.
Yes.
If you learn how to use a stethoscope as a doctor, you definitely can use ultrasound. Can you name someone, like dentist or surgeon do any surgery or dental work without X-ray?
Yeah, it's a good point.
It's going to be all aesthetic doctors, dermatologists, and plastic surgeons that they need a tool to see what's beneath the skin.
Yeah.
That's the thing. Like you are going to inject face full of vessels blindly. No, I don't want to dry what I don't have a good light. I want to see everything, and then is not only safety, now is precision.
Yeah.
And is people trust. People see you confidently injecting, and then definitely is the patient that asks for the doctor that using the ultrasound. And you can learn, but it needs to be translate. Like the anatomy, you have the anatomical knowledge of the face or body, you have all the surface landmarks, but definitely you have to translate it what you see as shades of gray, everything between black and white, but easy to learn. It's not like I'm saying it's without practice you can do it. You can do nothing without practice in your life.
I mean, I wonder whether that's true for all regions. I mean, in Australia, it's a pretty well regulated, sort of quite advanced industry, I would say, compared to some of the markets. But your average injector, even in Australia, if you ask them about their anatomy, it won't be perfect. Many people are not from medical background. We have nurse injectors in Australia. That's not to say that they're not skilled, but we know that the bar for competence is quite low because you can do a one-day course and start injecting. That's common in most countries. So, my worry is that even that foundation anatomy isn't there, and then they also don't have ultrasound. So it's almost like you're untangling two problems, a lack of anatomy and a lack of understanding ultrasound. What's your experience?
My experience is you should learn anatomy. Even if you are nurse, like injector.
If you don't know
if you don't know the anatomy, then you don't know what you're looking at. Even the radiologists say you're looking for something that you already know. Now you're seeing, I say, virgin tissue. You're seeing virgin tissue, normal tissue, and all of a sudden you see something, and you know that is not normal because you used to see whatever you were looking for. Now it's very important, especially in black market, because unfortunately there is a lot everywhere. I'm not saying even in underdeveloped country, it's everywhere that you see some permanent filler, some dangerous material and not good material, and you don't want to touch the patient with this. Is the safety for the patient as well. You're not touching, you're not getting headache. It's very important, and it's become essential for every doctor. You know the anatomy, now you start practicing ultrasound, you translate these to each other.
So I think that the challenge is that people don't know where to get started when it comes to learning. And there's also commercial implications as well, which is how much time is this going to add to my day? It's another process they have to do. So what would your advice be for people who either have an ultrasound, they're not confident in using it, or they want to get one for their clinic? Where do they get started in terms of understanding the basics? Because from my perspective, it seems like you're almost learning a new language. So how would you advise them to get started to, begin that process of education, becoming comfortable with it?
That's a good question. I'm, as a trainer, responsible to make it easier to understand. That's why I give them all the alphabetical, points, and then give them to make a point like this. Now, most of the companies, ultrasound companies, now they are toward the educational part. It wasn't used to be like this. They was just selling the device and then just leave you alone. Yeah. And then you will never use it. It's not even good for business part, because if people can't use it, they wanna, recommend everyone to not buying it anymore, right? That's why me as a trainer, I'm responsible to do it, and that's why I'm going worldwide like my colleagues, esteemed colleagues, like Leonie, Stella, there, and even some of the radiologists, very famous radiology that they started before that for dermatology, like Dr. Wartzman.
Yeah, from Chile.
She's a pioneer in the dermatology part, even medical dermatology, okay? And that's why we're going to just make it easier with the user-friendly devices. But as I said, practice makes perfect. You have to practice on yourself, on your family, on
your kids, it's fun.
everything. Yeah, it's fun.
That's what I did.
It's very fun. I was doing it on myself, you know, like, and then realize it's 5 a.m. and I'm still, you know, like doing it. In some part, I have to close my eyes and check supraorbital, and then with another eyes, I was scanning and looking at the screen.
Yeah.
But it's good if I'm, as a non-radiologist, learn to do it. It's not impossible for non-radiologists to learn and make it customized to their scope of practice. You know, like not every day, not for every single patient, but you can customize it. You know, first-time patients, just a scan to do whatever inside. Then secondly, based on the injection, see if you need to see the variation or the safer point.
Yes.
And then maybe, God forbid, for complication management. That's all you need. Yeah. Not every single patient, the full scan or for the full face. No, we don't need it.
I mean, maybe you would just be honest with your patients and say, I'm learning this new thing. Can I just look for 5 minutes in your face? And when I started doing it, patients are really interested because you can put the screen on their lap and you can just have a look together and say, oh, look, bite for me. And you can see this muscle moving. It's fun. But you don't necessarily have to use it for anything particular until you know what you're looking at.
Yeah, exactly.
So it's
and I can tell
fun.
you this story. We were on the conference and we were in the booth. It was dermatology conference. And then one of the doctor brought a case that couldn't fix the vascular complications.
Right.
Then was vascular occlusion in temple area. And they brought it, and me and my colleagues, we did it under the guide. And then patients right away feel no pain, and she was relieved. And then, you know what she said, the patient? I think all doctors should have this.
Yeah.
That's all. And now more people in some countries, even patients call the office that they say the doctor has the ultrasound.
Yeah, that's happening in Australia for sure.
Yeah.
I
They're
get
looking for it.
Yeah.
And because it make, you know, like confidence and clearance for you know, transparency for patients.
It's like you having a parachute on your plane.
Yeah. Yeah, you have it.
In case of emergency,
Yeah, you have it.
One of the big kind of debates, at least a few years ago, was, do I need to buy a big trolley mounted, very expensive machine, or can I have a handheld one? Is it good enough? So I know that you work with Clarius quite closely, which is a handheld device. So what's your sort of take on what should people buy?
In terms of choosing the device, you need something because you're working on superficial area.
Yeah.
You need at least a good resolution for 4 centimeter depth. It means that you need the device with high frequency. If it's the frequency higher, you see superficial. If frequency lower, you see deep, like abdominal, pelvic. It's a frequency of 7 something. But you need something. Clarius M20 has the best, you know, like resolution and the highest frequency, which is 20, yes. And give you the clear image to, you know, to scan and to assess. That's why in handheld devices, amongst all of them, Clarius is the best. But if you're looking at big machine and everything with the frequency of 70, for example, you are a dermatologist, you want to go with research, with everything, with the disease, nail disease even. You know, like now they're saying even in the medical dermatology, ultrasound is more accurate than MRI or CT. That's why you might need that one if you have this. But if you have a handheld device, you can put it in your pocket and go everywhere. It's my baby, always with me. Yeah, you can go everywhere, especially if you have a, you know, the multi-branch clinic and office. That's why it's better to learn with user-friendly one. It's like a, you know, like my example to my student is like that.
Yeah.
You want to just fly a plane?
Yeah.
Okay, you start with the small plane, yeah? But the good one, good quality, because it's your safety. You're not going to fly A380. A380, my favorite. One. No, it's just start with this. If you think that is enough, which 90% is enough for the aesthetics and even plastic surgery is enough, and dermatology, But if you think that you're good and then you want to invest more, thousands of dollars, and then that's fine. You learn and then you have it for the, portable one, and then you can get the bigger one.
Yeah, I totally agree with that. We've seen in the last year or two a finger-mounted probe by Dr. Asher and his team. So have you used that? I've not
Yeah.
seen it live
No,
yet.
I've used it.
Do you
I've
think
used
it's
it.
more practical, like more user-friendly, or not?
It's very good. It's very user-friendly, mostly for injection. You know that it's because for the guided, because we are as a injector, we need, like our hands free.
Yes.
I work with both, and I don't have any issue with all the machine as long as you learn how to use it. This one for the injection, it's kind of innovation, very innovative. It's a little bit curved. It's not the linear, but good frequency.
And the resolution's just as good as what you're using with the
It's
hand?
18.
Right, okay.
It's
So
18, and then
nearly as
this one
good.
is 20, but it's good.
So this plugs into the Clarius device. It's just a different.
No. It's a totally, I forget the name of the device.
Cybus.
Cybus.
It's safe injected by ultrasound.
Right,
Oh,
so
there you go.
it's like a probe
It's a
that
probe.
sits on your finger, so you
Right.
can actually use both hands whilst using the ultrasound. It frees up
Right.
a hand, basically.
Right. I mean, there'd be great emergency situations.
Yeah.
Yeah, that's
Yeah.
just.
It just means that you can sort of
Yeah.
more practically work as a solo injector rather than maybe having an assistant.
Yeah, I'm still with every devices are doing it myself, not with assistant. Even if it's my GE, Clarius, Cybus, it doesn't matter because I don't want to see everything while I'm injecting. You know what I'm saying? As long as, like I check everything before, I see the tip of my cannula is the exact same plane for the precision. I use cannula for more than 10 years, and then I'm still sometimes I feel I'm on the bone, and then I check with my device, and now I'm over the muscle.
Yeah, that's super interesting. I think ultrasound has made us much more aware of what we're actually doing rather than what we think we're doing.
Yeah.
I mean, I did the same thing. I was like, I'm sure I'm somewhere. You check with ultrasound, you're like, okay, it's not bad, but it's not exactly where I thought I was.
No, it's not. Especially when some area, for example, temple, 13 layers, and you want to go exactly interfacial. No, most of the time, based on a study, 89%, if you are going blind, you're not in interfacial.
Yeah, I read that study, but it was a small cohort, and interestingly, they were in fact, they were all plastic surgeons.
But I'm checking it, but not with numbers,
Yeah.
with my students.
Yeah.
Whatever I'm teaching the temple, I check. Either we are below, because it's easier to go below in intermediate path, and sometimes superficial.
What do you think the most impressive advancements are in terms of the technology, in terms of usability? Like what's changed in the last few years?
Artificial intelligence.
Right. Okay. And how's
I
that?
would
Yeah.
say
Okay.
because now I'm working with Clarius, but this AI, which I'm as a medical advisor, just help them to improve and then update it. It show you different layers.
That
It's
was
a
cool, the
T-mode.
color-coded one,
T-mode,
right?
Right.
yes. And then now much more to come
All
to
right.
help doctors to, just
It sounds like you have a
visualize everything.
secret.
Yeah, it's a secret. Yeah, it's a
We're going to
secret.
speak to you off camera
Yeah.
and get these secrets.
Can you
Yeah.
give us a clue?
Just different material.
Okay, that's interesting. I mean,
Help you to,
one of David's points, and we've spoken many times about this off camera, was if you don't understand the language, it's almost like me trying to learn Chinese. It's just too difficult, and many injectors are just put off by ultrasound. It just looks too alien to them.
Yes,
That any
exactly.
gray kind of
Yeah.
stuff looks like the same. So with the T-mode, I mean,
T-mode?
Yeah.
It's educational, they're not saying this one, it shows you the layers, the skin, the fat, bone, muscles, in some area, in body, breast, in BBL, and some part of the face. It's going to cover all over the face and some different product.
Yeah.
And then the thing is, can I tell you the story? As I said that I'm a non-radiologist and I learned how to do it. Just recently, I had the, checkup ultrasound for myself for abdomen, pelvic, and thyroid. And then I was looking at the screen, I was lying down and then looking at the screen. The screen was toward the technician. And honestly, I saw something. I saw something in gallbladder, I saw something in thyroid, and then, like I have to, check quick. It's not a stone based on that shades of gray.
Right.
It wasn't gallstone because it wasn't white with a posterior shadow, which we call it in ultrasound. And then the other one was a nodule that I see in different shape, different things. You know what I'm saying? You become very fast to see what you're not supposed to see.
Yeah.
That's why I'm telling all my colleagues to start with the virgin tissue. Start with someone's face that never done any filler or implant or even Botox, because it changed the thickness of the muscle. It changed because you can see the contraction. It's a real-time scanning. You can see all the movement and everything. And then after that, if you see something inside,
It jumps out at you.
everything, yeah.
Yeah,
If it's not normal.
It's not normal. It's easy. It needs time for sure. It takes your time, but it's for future. Some doctors say, they compare this with a laser machine or HIFU machine. They say that I cannot make money directly from the machine, but I'm telling them it's a long-term investment. You get more patients that they know what they want.
Yeah.
And then you being confident, less complications, more precise treatment, and you build your business.
It's a slow burn. You're not going to become successful and rich overnight. It's about, as you said, putting all the right processes and systems in place, exposing yourself to it slowly over time, building up your familiarity, because humans are really good at pattern recognition.
Yeah.
Once you see something enough, you start to build up a memory bank and you start to notice things.
Exactly.
And it's just, I think people sometimes get to a point in their life where learning a new skill is very scary. Like when we're a kid, everything is new. It's okay to be not good at something because you're a child. Everyone expects that. But as an adult, sometimes it can be an ego that makes you feel like silly for not knowing. Do you think there's any truth to that?
Yes, it's true. And there is a study for this.
Oh, yeah?
They said that if you practice something, new skills, in the language, is ultrasound or whatever, and you just use 20 minutes a day, but constantly, every day. And then at the end of the year, you are ahead of 80% of people around the world because you were constant, it's just you do it every day, not, that Duolingo.
Yes.
Okay. Then you learn, they were so happy that all, and then after that it's become grumpy because we miss you.
Yeah.
Because you have to learn every day. That's why I encourage you to do it.
Yeah, my partner learned how to do it. She taught herself how to speak German, and she was doing every day like an hour, and she would say, and they make a competition out of it, like a game. Like if you do, you people are catching up to you, and the little, is it an owl or something? It gets angry at you, and you.
Yeah, it's amazing. It's always mad at me. Sorry.
Yeah. What language are you learning?
French.
Oh, that's a tough one.
French and
Maybe go Spanish. Oh, Spanish is easier, I think.
Together.
Oh.
Yeah, I love it. But,
Okay.
I was in Tunisia for ultrasound.
I speak French there.
They say, do you speak French? I said, no, je ne peux parler français.
Yeah.
And they said, then you know that to say, I don't speak Français. I just stuck this
Well, there we go. You're learning. 1%.
It's like muscle memory.
Yeah.
It's muscle memory. You just got to get enough repetition.
Exactly.
And then eventually it becomes a thing.
Every day, ultrasound on yourself, your family.
Hey guys, sorry to interrupt your podcast. Just a quick message about our Patreon and how you can support us as a podcast. So David, what is Patreon?
So Patreon is an on-demand subscription service that allows you to access our global community of practitioners, business owners, and essentially it's a place where you can come together, get positive support, advice. Whether you're a beginner or an experienced KOL, there is a place for everybody.
Yeah, so if you download the Patreon app, search for Inside Aesthetics, there are two main options to subscribe. You can become a free member where we can communicate with you, share our news, involve you in competitions, etc. Or you can become a full subscriber for 50 Australian dollars a month. And there you get access to the WhatsApp community where people are sharing and getting advice. But also within the Patreon app, David does a lot of business coaching and mentoring. So I think you've drilled down to various topics that have cropped up that have been communicated in our WhatsApp group.
I mean, just today we recorded some content. It's quite a nuanced space, and the challenges that business owners and practitioners come up against in this space is quite difficult to get advice on. So always happy to share my knowledge and all of my mistakes and lessons learned along the way.
And then I, of course, tackle injectable content. I often involve patients or talk about new products, anatomy, and all that good stuff. So if you like what we do, consider subscribing to our Patreon. Now let's get back into the podcast. You mentioned Botox.
Oh, yeah.
And do you see a role for using ultrasound for Botox regularly? I mean,
You're talking about all toxins, assumingly.
oh, sorry, all
Yeah.
toxins.
Yeah.
Yeah, botulinum
Toxin,
Yeah.
yeah.
Because on the one hand, I don't think we have that many problems doing it naked eye, just sort of doing our usual injections. But if we're thinking about it, we're trying to put a toxin in a muscle, not around a muscle, to reduce the risk of complication. So why not use ultrasound?
That's a good question about the botulinum toxin. Mostly, I use ultrasound with botulinum toxin for masseter muscle, for bruxism, for DAO, because most of the time we scare of getting complications, especially when we do a toxin for DAO, but we don't see the result because you're so superficial. And DAO is a bulky muscle, especially in the midway from the commissure to the mandibular ligament, right? And then I do even marking with ultrasound, scanning before the treatment, or do under the guide, because exactly I can go to the bulk of the muscle with no complication, not touching DLI. Yeah. The thing for masseter muscle, we need to get that three head, like intermediate, superficial, and deep. And from one point, we can, just target all three. The other indication for people that they don't get the result, for example, for the forehead in men sometimes, and for CrossFit for the men, because sometimes they don't get proper result when we do it blindly and we go very superficial or very close to the orbit because they have a wide orbicularis oculi. Like for some people that they don't get the result, or some area, for example, the masseter muscle and the AO, I do under the guide.
It's interesting, isn't it? Because we've got a lot more toxins coming onto the market now, and some have, you have to be more precise with them. They don't have the same degree of forgiveness, with disbursement.
Yeah.
And that's why a lot of people just don't know what they're actually hitting because they've been used to a product that's more forgiving.
Correct. And then blaming toxin resistance
it's
instead of
a
actually
bad batch.
dispersing the muscle. Yeah.
Yeah, okay, exactly.
Exactly. Yeah.
Send the badge.
Now, I'm guessing you're going to say yes to this, but do you agree that ultrasound is still the gold standard for treating VOs, or do you still think there's an acceptable practice that we do it naked without, any special visualization? What do you think?
No, I think it's going toward the ultrasound guided for vascular occlusion, because in some area you cannot float.
Yeah.
In some area, you have to go intravascular. It's hard. Sometimes you cannot go intravascular, the exact same of the occlusion, but you have to go proximal and then shoot your ultrasound. And for blindness, even more expert, they are injecting to supratrochlear, supraorbital, yes, which is better instead of blindly going ultrasound guided.
Yeah.
Just God forbid, it's rare complication, but it's still. In some, it's not only vascular occlusion needs ultrasound guided. In some area, for example, it's very common to find a pocket inside the parotid gland.
Yes.
And parotid gland, as a salivary gland, you cannot float hyaluronidase. You have to go and shoot like a sniper, right?
Yeah, straight into the lump.
To the lump. And for granuloma injection as well, because granuloma, one of the medication that we are using is the steroid, and you don't want to get normal skin to be atrophied. Intralesional injection. For more of the complications, you need the guide of the ultrasound.
So from what you've seen under ultrasound, do you think that VOs are actually an occlusion of the vessel, or do you think it's an irritation of the vessel from filler outside the vessel, or both?
Great question, because it's a different, thesis about this. Some, they said that it's going, the vessel's going to the spasm, but the most thing that we see that perforator cut off, and then you see the silent area with ultrasonic sign of inflammation, okay, which is the change in echogenicity and shades of gray. And then just in adjacent structure, you see the dermal perfusion, which you cannot normally see with these devices, okay? Dermal perfusion means that something shouting that I'm suffocating.
Right.
And then it's all the linking arteries, vessels, they're going to the area to help.
Okay.
That's why you see this sign of inflammation, silent area, and then
everything
just
around it
close
looks angry.
by. Yes, you see this
Interesting.
hyper kind of vascularization, but mostly dermal perfusion.
So in that situation, what are you targeting? What your highlights? Where are you actually targeting? Can you see the filler, or are you trying to just go around that sort of cold zone?
Sometimes you see the filler, but most of the time you don't see because the small pocket, a small emboli, a small drop
Yes.
is, we call it anechoic, black. And black in black, because vessels is anechoic as well. You cannot see it. Okay, mostly you cannot see it, but you can find the proximal part of the artery and go and inject inside the artery.
Yeah.
And as well as on top of the superficial upper aortic system to just open all the linking and perforator.
So beyond injectables, are there any applications for other treatments like regenerative skin tightening? Are you using it in other parts of your practice?
Yeah, exactly. That's a good question because we are doing it for HIFU.
Right.
If you have Ultherapy, which has the ultrasound screen or something, but most of the machine don't have the real ultrasound screening. Okay, that's why what we do and so many dermatologists do, they are going to map the area that's going to do the HIFU and then check the depth of the SMAS or platysma. And every single area is different depth. Every single patient is different depth. That's why you can pick the proper cartridge for the specific area and get the result, not make the face slimmer. Because if you're going superficial, we melt the subcutaneous fat.
Yes.
Imagine that you have a patient with a slim face and you make it slimmer.
Yeah, we've seen this.
It's
Yeah,
quite a
and then
controversial topic,
yeah.
isn't it? We know whether these devices actually do melt the subcutaneous fat.
Well, I think it's just a case like Roya
Yeah.
said. It's just they've targeted the wrong layer.
Yeah.
It's more superficial because, for example, if we are saying a SMAS is at 3.5
Right.
and I'm using 3.0,
Yeah.
you melt the fat. You're not reaching to the SMAS.
Right.
And you have the chubby face, you want just a little melt the fat and lifting effect on the SMAS, then you have to, scan. You cannot see it blindly. You cannot tell blindly. I had the chubby face patients that the SMAS was very superficial.
Right.
And you can go deep, you think that is deeper, you can go deep and you damage the nerve.
Right.
That's another story. Damage the nerve, melt the fat, not the actual treatment. This one is good. The other thing is based on the echogenicity, based on some sign in ultrasonography, you can find out if your anti-aging treatment was efficient.
Right.
And we can tell based on the collagen stimulation in deep dermis, reticular dermis, based on echogenicity of upper dermis, based on some blackness, which call it a SLEB, subepidermal low echogenic band between epidermis and upper dermis, which happen to see for aging, after aging, or sun damage, you see this black line. After the treatment, it become more smaller or it can reverse it.
Wow, interesting. That's really interesting. Yeah. So when you're doing your training with Clarius, and I know you've been around the world sort of teaching different populations, how long does that learning curve take, would you say, for your average injector before they're sort of proficient enough to start using it in a simple way in their clinic?
And you assuming baseline level of like anatomical knowledge and
It's just average. I don't know what average is, but
Yeah.
average.
Like if they listen to me and they practice every day, honestly, after 2-3 months, they can do a scanning every day.
Yes.
And with everyday scanning, they get, experience, they get, like more to see. And then after a few months, they can use the ultrasound.
Yeah.
It depends on them.
What does the training sort of look like? Is it a one day or is it online? Like, how do you do it?
We do one workshop and then we ask them to, I I give them basics, even the basics about physics. Yeah. And then I tell them the orientation and all the coordination between the hands and the machine. What you see, where is the superficial, where is medial, lateral, caudal, cranial. And then I supervise them to this coordination on the phantom or just, simulator.
Yeah.
Mostly I would tell them, like on chicken leg.
Yeah.
Or exactly,
Why
with
not?
the bone, because it has bone, skin, and
Yeah.
then subcutaneous fat, everything. And then they were doing, and then now I asked them to gradually just involve this in their practice. Not for every patient, just trying it.
Yeah.
And then some of them, they take a private course, one-to-one, hands-on, if they want to, learn more. It depends on them,
Okay, I have a controversial question for you. Is it your opinion that medical societies and regulatory bodies around the world should mandate ultrasound both to be present in the practice as well as training to make sure competency? Do you think that's what we need?
Yes, I think it is. Because, as I see, since 2019 or 2020 until now, those days, we didn't have too much ultrasound session in congresses. Now, every single conferences had workshops, had live demonstration with ultrasound, including this ICCE this year, Professor Katafana as a scientific director, just, he doesn't allow any filler injection, live demonstration without ultrasound. They have to have the ultrasound. It's become mandatory, and I'm always say that whoever start to learn, sooner, they are ahead. In Florida, I would say, it's mandatory to do BBL
Yes.
ultrasound.
It'd be crazy not
It's
to. Yeah.
mandatory. Yeah, it's mandatory because you are so close
Dangerous, yeah.
to just go into the muscle and vein, and then a pulmonary emboli and death. And for the face, it's the same, vascular occlusion, damaging the skin, blindness, safety, precision, and definitely become mandatory.
Wasn't there an occlusion that happened at a demonstration in the last couple of years? I think we were talking.
It's a bit controversial,
Yeah.
but it was thought to be, I'm looking at the IBSA stand here, it's thought to be with Profiler in the neck.
Right, okay.
But, it was easily managed.
Yeah.
And it wasn't like a major drama. But look, these things can happen. They're live patients, right?
Yeah. Well, actually,
So-
Stephen Liu did like a mock one. He pretended he had an occlusion.
Yeah, at one of our
Yeah,
conferences in
yeah.
Australia about 3 years ago. This is kind of amazing.
Yeah.
Do you know Stephen Liu? He's a plastic
Yes,
surgeon. Yeah,
of course I remember. Yeah.
Shout out
he,
Stephen,
he
yeah.
created a mock blindness, but he didn't tell anyone. And the whole audience was like, oh my God, what's happening?
Yeah.
And it took like 3 or 4 minutes for him to reveal this is not real. But I want you to know what you should do in real life. It was really
And I
well
watched
done.
the video that he made
Yes.
in the office.
I used to-
as they call it 6C or something. Yeah, I know that. Yes, it's very scary. It's very scary, but definitely it was. I was teaching aesthetics injection, and I had a model.
Yeah.
Never had any surgery around the nose.
Yeah.
And then I said, okay, let's inject with needle. And then I said, okay, let me show you what is safe mapping.
Yes.
And I did mapping, and I find 2 angular artery, 1 on the bone, 1 superficial. What are you gonna do? You're not injecting? Of course I'm injecting. With the cannula, 22 gauge, with more caution, caution, and then all the safety precaution, even with cannula, with safe mapping. But still, you wanna inject blind?
Yeah.
So many times I'm seeing vessels, anterior deep temporal, very close to the swift point.
Up until I got ultrasound, I was always doing the swift point or one up, one over, whatever you want to call it. As soon as you start looking at enough patients, even just 10 in a row, and you see this vessel sat right on the bone where you're told to go, you're going to change your practice overnight. And I did. So now...
Or change the point.
Or change the
sometimes
point.
I change the point. In my class, I feel pause.
Yeah.
I check with the ultrasound. I saw the anterior deep temporal, and it runs a little bit, zygomatic-temporal, going into the orbit. And I change my point, and I give it to my student to inject.
But it also forced me to think why am I doing this? Not just for safety, but aesthetic result. I think you get a more efficient use of the product in that interfacial plane,
Exactly.
and it's safer. So it's
Yeah,
like a double
it's safer.
whammy.
Yeah.
It's safer, but it's still you have to be careful, even in
nothing's no risk.
interfacial.
Nothing's
Yes,
no risk.
yes, of course.
Yeah.
But sometimes it's very for a skeletonized face. Sometimes
Yeah.
with interfacial, you cannot give that volume.
Yeah.
You
Yeah.
still might need that supraperiosteal, but it's not as easy because first thing that they teach doctor is go straight on the bone, one up, one over, and done.
Yeah.
Now we are saying no. Do the safe mapping. Either you want to do it or go with other techniques.
Yeah.
Yeah.
I think part of the resistance as well is that people that have never experienced an occlusion, they've had
I
practice
think
for
it'll never
many
happen
years,
to me.
and maybe they don't realize that they're probably causing occlusions all the time, but they're minor, they're small vessels, they're inconsequential, they self-resolve, but they don't realize just because it hasn't manifested into like something serious,
Yeah.
that they've never caused an occlusion. They've just been lucky enough that it hasn't been, in a bad place.
So to your point, I think a lot of injectors who've never had a problem think, well, I haven't had a problem yet. I won't learn anything new. But those people who get an occlusion who need help from someone like Roya, I didn't realize how bad things could get. So hopefully that motivates you guys to, maybe invest in this before you have a problem.
Yeah.
We've actually got an IA offer with Cutaneous Ultrasound, the guys from Holland. So just check out the link in the podcast, and you can do their online modules, just learn a bit more about it, and then maybe commit to, an in-person course with Roya.
Yeah, we did a podcast recently with one of our patrons, Hayley from Perth in Western Australia. She owns a very successful business in Perth, in Australia. And one of her staff was injecting her temples with Radiesse, and she had a very serious occlusion.
Yeah.
And was rushed to hospital, hyperbaric chambers, tissue necrosis, everything. And we actually covered, her experience. We got photos of what actually happened in our Patreon as well. So that was like a real life example of someone who's relatively experienced injector, hadn't had an occlusion before, and the first occlusion that happened was on her.
Yeah.
So I think it was a big wake up call to, not that, wasn't before, but I think, when it actually happens, it's very different to like knowing it can happen.
Yeah. So shout out to Hayley for sharing that.
And
I guess final questions. Where are we going with this? Like, where's the technology going to get better and better? What are your predictions?
Yeah, of course.
your
Technology
crystal ball.
Technology is just blooming. It's not. It's going toward more user-friendly devices, very lighter. Yeah. As we can see in some devices, they're not heavy, and it's not make your hands like exhausted or sore. That's you can use it, and then more toward you do it more customized. Yeah. Maybe for different specialty. As we have different handpieces for different specialty or handheld, you can put it in the pocket, and wherever you go in the emergency room, in your office, you can use it. And then, as I mentioned before, AI is very helpful for this, as long as you are using it properly. And then, yes, it helps a lot in technology.
I wonder if we could train the AI to actually visualize the filler, like show it lots of examples of real filler on a real scan, and then like train it, and then you could almost like show it up like a ball.
Yes, of course. Surprise.
So maybe that's coming.
Yeah.
Who knows? Yeah.
And what about being actually able to see in real time, like have a probe actually on the end of the needle, so you can actually
like a robot.
Yeah, we actually, because it's so precise, like a millimeter. You might look like it's okay, and then you move like your hand shakes and you're in a different spot all of a sudden.
But we can even with nowadays technology, we can see it. We have like needle enhancement, which make needle more clear.
Yes.
What's this? Sorry, the needle enhancement?
Needle enhancement is one of the settings in AI for Clarius that then you can turn it on, and sometimes because of the angle of the needle, you might not seeing it, but it make it more clear. Yeah. And you can see it. But it's still, with the needle enhancement, you have to tell the AI your needle is coming from this side or this side. With the just touch, you can bring it right or left, but easy, like you can see it. But the echogenicity of the needle or cannula is one of the easiest thing to find. But definitely it become better and better and clear to see different things.
Exciting time.
It is. So do you have any final messages for our audience in terms of, getting started with ultrasound today? Any advice for people that are, still on the fence, they're scared, they don't know where to start?
The only thing I can say is try to see what others can't see. That's the thing, you know, like always be confident, be safe, and be more precise.
Yeah.
Good advice, Roya. Well,
Totally.
thank you so much for your time. It's been great to see you after a couple of years.
Oh, thank you so much for having me. It's a pleasure to be here, and see you guys.
Thank you
very much.
Thank you.
We hope you enjoyed that episode, guys. To stay up to date with our latest news and episodes, follow us on Instagram, and we're now on TikTok.
You can also now watch our full video episodes on YouTube and Spotify. So if you like what we do, please give us a like and subscribe. Please also consider joining our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, hints and tips videos, bonus podcast content, and more.
All of our social links, Patreon, and contact information are in the show notes below, and we'll see you in the next episode.